Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you for the introduction. I think because the session was brief, I tried to keep it very focused. And really the goal of this talk is to help answer the question of what is that brain lesion in my patient with HIV who has a CD4 count less than 50. So we'll go through some of the most common causes. This is not an exhaustive list, but just kind of a thought process that goes through my head whenever I see cases like this. I do have research funding from NIH, from CFAR, and from Bayer Pharmaceuticals. So the disclaimer. And this is a case-based format, and it is meant to be interactive. So please chime in. Thank you, everyone, for keeping your cameras on. It is incredibly helpful to see people's faces. So our first case is Mr. P and the headache. It's a 36-year-old man. He is living with HIV, immigrated from Mexico recently, and presents to your clinic in the urgent clinic with a headache and acute onset left arm weakness. And kind of briefly, as a review for most of you, these are kind of the key history questions that are relevant to individuals living with HIV who present with a new onset neurologic symptom, their current CD4 count and viral load, whether or not they're on antiretroviral therapy, what stage of HIV infection they are at, and any prophylactic therapy, any recent exposure to opportunistic infections or conditions that predispose you to opportunistic infections such as travel and other animal exposure histories. So as a broad overview, and I think this is kind of the key slide to keep in mind for anyone presenting to your clinic with a neurologic condition, is the timing or the phase of infection, and then what common neurologic conditions present in each time. So during the early stages, the acute HIV stage, which is predominantly in the first few weeks of infection, we can see meningitis, encephalitis, acute onset peripheral neuropathy, but sometimes that actually presents as Guillain-Barré syndrome. And we have seen acute onset cranial neuropathy. And I do have one case of transverse myelitis during this acute period. So just some conditions to keep in mind as rare presentations in acute HIV infection. Then, as the group knows, there is this latency period that is variable in different groups, in different people. And in this period, we can see both in treated and untreated patients, distal sensory polyneuropathy. That's probably the most common condition that I see in my clinic. Other inflammatory demyelinating polyneuropathies such as CIDP falls into this group. I've seen myopathies and mononeuritis multiplex. So definitely the neuromuscle spectrum during this phase. And the focus of this talk is actually going to be in conditions that present in patients with AIDS. So this is much, much rarer, thankfully, to antiretroviral therapy, but dementia is a common condition in patients with untreated HIV. We see toxo, tuberculosis, PML, CNS lymphoma, CMV, cryptococcus, and then you can also get distal sensory polyneuropathy in all of these stages. So by no means an exhaustive list, but something to keep in mind, and really kind of the differential of patients presenting with AIDS to your clinic with acute neurologic symptom. So let's go back to Mr. P and the headache. So this 36-year-old man who is living with HIV, who's from Mexico, and had acute onset headache and left arm weakness. So his CD4 count is 30. You sent for a viral load, but it hasn't come back yet. He's been off of antiretroviral therapy for 2 years, diagnosed with HIV in 1991, not on any prophylactic medication, had a recent presentation to the emergency room and was diagnosed with CMV esophagitis, and was coming to Madison Clinic to reestablish care and wants to start antiretroviral therapy. So you miraculously get a urgent MRI scan and it gets done. And this is what you see. Any brave volunteers want to describe the lesion?
Payal, I'm not sure if you see, but it says big, it says ring enhancing.
That's awesome. Yes, it's a very big ring enhancing is spot on. So you see the T1, and it purposefully says with gadolinium to point to the fact that this lesion here has contrast enhancement. What about on this side?
I don't know if you see in the chat, someone said multifocal masses with vasogenic edema on clit.
Perfect. So same, you see another lesion that is better visualized on this slice of the skin here. This lesion also has ring enhancement and there is extensive edema. Perfect. That is exactly what I wanted you to see and pick up on these MRI scans. So, focal CNS lesions in immunocompromised patients. In this particular patient, what are some of the etiologies that you are considering? What's the top one or two? Toxo and CNS lymphoma, those are the top two. So toxo is by far and away the most common cause of CNS lesions in patients with AIDS. That shows up time and time again on our board exam. I bet it shows up on your board exam too. But that's kind of why we started with this case, is that the top two things on our differential are CNS toxoplasmosis and CNS lymphoma. And we will talk briefly about how we try to tease apart between these two conditions and the treatment of these two conditions. And of course, the list is long about what this could be. And that's where the history and exam really comes into play. But that's a list by no means extensive. And then you can also see non-HIV related diagnoses. And one case that does come to mind is actually a case that presented in a patient with HIV who was very young, had recent travel to Mexico, and had a single lesion with an extensive cyst around it. And we were initially thinking, oh, this is neurocysticercosis. It has to be neurocysticercosis. It looks like neurocysticercosis, and it actually ended up being a vascular malformation. And so just to keep in the back of your head, you know that there are a lot of things that present like lesions in the brain. They're not always infectious, even in patients who are at high risk of having opportunistic CNS infections. So this is adapted from a slide set that I give the fellows, both the neurology fellows and the ID fellows, and I just throw out a whole bunch of images of what CNS toxo looks like here on the CT scan. Classically, ring enhancing, you can see two separate lesions here and extensive edema. So those are the things to really look out for: ring enhancement and edema. Again, ring enhancement and edema. And then, because board exams always love pathology for some reason, this is what toxoplasmosis looks like on path. So this is a muscle biopsy, and you can actually see the tissue cyst filled with bradiozoites of toxo. So toxo typically happens in patients with AIDS who have a CD4 count less than 100. The most common cause of CNS lesions in patients with AIDS can present with fever, headache, focal neurologic findings on exam, and seizures in 15 to 40%. And the diagnosis is through serology, which has a high sensitivity and a high specificity. So negative serology should prompt consideration for an alternative diagnosis. There's the treatment regimens, which you all are better versed at than myself. And if you see this classic finding on imaging, you should start empiric treatment while we wait for the diagnostic test results to come back, because there's very little else that looks like this. The other thing that looks like this is CNS lymphoma. So CNS lymphoma doesn't actually classically have that ring enhancement, so that's the classic sign. But oftentimes the cases that we present are not how our patients present. So primary CNS lymphoma is the other consideration in patients with AIDS who present with CNS lesions. This is, of course, different from systemic lymphoma. It's a high-grade lymphoma that's isolated to the CNS and is associated with EBV. It occurs in patients with CD4 count less than 50. Same symptoms as toxo. Focal neurologic findings, low-grade fever, headache, seizures, malaise. But what is a little bit different from toxo is that CNS lymphoma has more of a subacute onset. So you can see, rather than this acute focal neurologic deficit or a series of rapid onset focal neurologic deficits, CNS lymphoma has more of an indolent course, usually, not always. And the primary clinical features of CNS lymphoma are that you can have a normal CSF profile. Sometimes you'll see an elevated white blood cell count, and with that elevated white blood cell count, you'll have elevated protein. CSF EBV PCR is very sensitive and specific, but it doesn't diagnose CNS lymphoma. What you need to diagnose CNS lymphoma is cytology, which is really difficult to obtain. It's very insensitive, but once you capture the cells that are classic for CNS lymphoma, then you know that you've arrived at the right diagnosis. So sometimes in patients where this is a suspected diagnosis, we do LPs 3 or 4 times, a high volume LP, and then send it to pathology looking specifically for this. There's not a lot of treatment options that are available. The treatment involves antiretroviral therapy, of course, and then intrathecal methotrexate is a treatment of choice. It's been shown to improve median survival times from 2 to 4 months to 1.5 years. Whole brain radiation therapy is an option, but really has limited benefit and gives you high morbidity in the acute stage. So really trying to preserve quality of life in these patients is the primary goal. And so most people shy away from whole brain radiation. All right, so that's kind of the big guns. Before we jump to the next case, this is our second case, Mr. M and gait difficulty. So the 36-year-old man has a 10-year history of HIV. He was on antiretroviral therapy from 1999 to 2001, lost his insurance when he lost his job and couldn't afford antiretroviral therapy, and was lost to follow-up, but came back to the ER in January of 2002 with difficulty with balance that had been progressing over the last 4 weeks. On exam, you see nystagmus and appendicular and gait ataxia. You get a CT because he's in the ER, and this is what you see. It's poor quality, but this is what happens in real life. Brave volunteers? Yeah, exactly. There's something in the cerebellum, right? And oftentimes when we get a CT and we have a cerebellar or brainstem lesion, we see that there's something there, but we need better imaging in order to really clearly define what we see. So we get that. And this is what we see on MRI. No ring enhancement or something in the left cerebellum. What else is, I guess, compared to our last case, different about this one? Exactly, Amy. No ring enhancement, not well defined, and then the white matter. So white matter, no edema, no enhancement, although this kind of a giveaway is that I didn't share the picture with contrast, but you don't see edema here. So back to our patient. His CD4 count is 241. He does have detectable viral load of greater than 500,000 copies. We saw the neuroimaging, and you guys were spot on. White matter abnormality in the cerebellum with no mass effect and no enhancement. So mass effect is another term for edema. So no edema, no enhancement. You tap him and it's completely normal. His routine studies are normal. His VDRL is non-reactive. JC virus is negative. And so you say, I'm not really sure. I'm going to send you to the neurologist, and you can't get in to see the neurologist because there's no openings. You say, come back and see me in a week or 2. Comes back in 2 weeks, and he has progressive worsening of his left face, progressive worsening of his weakness. It now involves his left face. He's now developed dysarthria, dysphagia, diplopia, and he can't walk anymore. You say, okay, we got to admit you to the hospital to really figure out what this is. you get a repeat scan, and on repeat scan, you see that the lesion has extended. There's still no edema. There's still no enhancement. What do you think is going on?
Payal, this is Brian. I'm still worried about PML. Is that appropriate or not?
Very appropriate, and exactly the point of this case. So you tap him again because we're looking for what this could be. JC virus this time comes back positive. The PCR comes back positive. You had already reinitiated him on antiretroviral therapy. He continues to worsen for another 2 months and then slowly has some small improvement. And 18 months after his presentation, he still has persistent dysarthria, ataxia, but is able to do most of his ADLs. His CD4 count is 800 now, and he is virally suppressed. So this is what PML looks like on path, just FYI. This is myelin staining. And then silver staining here actually shows that the axons are intact. And then this is a myelin stain, a Luxolfast blue stain for myelin. You can see these patchy areas of demyelination here. So PML, we typically say, happens in individuals with a CD4 count that's less than 200. But people who are on this border of CD4 counts between 200 and 300 can often present with PML that have a more indolent course. It happens in 5% of patients with AIDS, and it's common in healthy adults to have positive titers for JC virus, and there's latent JC virus in their kidneys. But in patients with HIV, what PML presents as is a focal neurologic deficit with really no other infectious features, so no fever, no headache, subacute onset over weeks and months. And typically the CSF profile is completely normal. And the really point to remember with this case, as Brian brought up, is that even though JC virus PCR in the CSF has really good sensitivity and specificity, actually that pre-CART era was something that's a holdover from other slides and something to ignore. But that's the sensitivity and specificity in patients that are not living with HIV. But in patients who are living with HIV, JC virus PCR is actually pretty insensitive. So there's two things that you can do if you do have strong clinical suspicion based on the presentation and MRI findings. One, you can repeat the TAP and send for PCR, and then at certain centers, including at University of Washington, we have an ultrasensitive JC virus PCR. So if you have a strong clinical suspicion that this is PML, then that would be what one thing that you can send. Here are some pictures of what PML looks like in other scans. And I show this to show that it can often involve the brainstem, doesn't necessarily only have to involve white matter. Imaging usually demonstrates abnormalities in the white matter, but can involve the gray matter, especially in individuals who are severely immunosuppressed. Extending to the subcortical U fibers, what that means is that the U fibers are actually the area that is juxtacortical to the gray matter, so the area of white matter that abuts the gray matter. In metabolic conditions, which also commonly present as white matter conditions, you actually see sparing of the subcortical U fibers because that's an area that doesn't have high metabolic demand. And so you see, as someone really pointed out really well, this very not clearly defined white matter lesion. And that's classic for PML. It's hypodense on CT, bright on T2 and flare, dark on T1, doesn't have edema or mass effect on neuroimaging. Rarely you can see enhancement though. So 7 to 10% of lesions will enhance. Most cases are multifocal. For the sake of time, I'll kind of speed through this. There really is an effective therapy. Reinitiating antiretroviral therapy is key. Usually you see a decline initially for the first few weeks and then stabilization. When you repeat imaging, you can actually see atrophy in the areas that you had the lesion in previously, as demonstrated here. Immune reconstitution, here's a MRI example of that, is rare in PML, but happens, and something to keep in mind if you see the clinical features of immune reconstitution, but also all of a sudden the lesion begins to enhance. Another path slide of PML that comes directly from our board exam. So thank you for letting me present and being an interactive group. This is how to reach me. I do have 2 research studies that are ongoing, one in adults with perinatally acquired HIV who are virally suppressed. And that particular study, we actually are able to cover flights for individuals. That's my research email for my research team, cip21@uw.edu. So if any one of you is seeing an adult who has perinatally acquired HIV and is interested in getting cognitive testing and a scan and flight covered to Seattle, please do let me know. That's my personal email address below, pbp22@uw.edu. Thank you.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.